How has it changed? Well, the technology is about the same. The basic aspects of that existed before COVID-19. There have been a few new additions here and there, but for the most part it was the same. The biggest change has been that a lot of the previous regulatory and/or insurance payment-related barriers were struck down once COVID-19 showed up. So those of us that work in this area had spent a lot of time battling, trying to get those things improved, trying to talk to regulators and explain to them how the current regulations were impeding not just the growth of telemedicine, because that's again sort of a corporate-y type phrase, but real things like people dying, real people dying as a result of not having access to the appropriate expertise, not being able to see a certain type of doctor that they needed to see. Those were real stories, and so we would take them to the regulators and try to share those. That happened at the Medicare level, it happened at the state level, and frequently we were greeted prior to COVID-19, we were greeted by very positive responses, but very little concrete action. Some things, but not much. And I'm sure there were a variety of different reasons for why that occurred. When COVID-19 showed up, literally within weeks, we saw all these different kinds of things that had previously been established as barriers struck down. And to date, at least up to the time of this recording, many of them still have not been put back in place. And we hope actually they won't be put back in place because the things that they were meant to protect against, the value of preventing those things was much lower than the harm they were causing unintentionally by preventing us from doing things we could do. Easy example of that would be when we were trying, for example, to, in the early days, it would be just something as simple as, if I see a patient virtually, can I just be paid for that by their insurance company? The answer was no. So it's like for a lot of, so for some of us went out and saw patients anyway during that time period. We did that. But a lot of other doctors were like, I want nothing to do with this, right? If I'm not going to be able to be paid for this, if I have to fight somebody for the payment, then forget it. I don't care if my patient has to drive 4 hours from somewhere to come see me in my office. Like, I got to be paid. So if you don't pay for it, then I'm not doing it. That's real. I mean, that's not a made-up story. That's the reality for people, right? We also saw situations, for example, where many of the small rural hospitals could be staffed much more effectively. And when I say effectively, what I mean is cost effectively, but also even in terms of the quality of care that we could offer. We could offer many more services, do a variety of other things for people in those smaller communities if we could do it virtually. But because of some of the regulations that existed at the CMS or Medicare level, we couldn't. We just simply couldn't. So as a result, the hospital, which already had low volumes, was having to pay enormous amounts of money to fly a doctor in to the facility when there was no need for that, right? There was no need for it medically, but there was a need for it based on regulations. Here again, COVID showed up, almost all of these regulations got struck down, and so we were able to make more progress in terms of the types of clinical service that we could offer as a result of that change. Hopefully it will remain the same.